All right, today we're diving into the incredible clinical world of a twin pregnancy. It's a journey that's unlike any other, really. From that very first ultrasound to the final intense moments in the delivery room, managing two babies at once is a story of precision, planning, and some pretty high stakes. So let's get into it. And that really is the question, isn't it? Is having twins just twice the joy, or does it bring on a whole other level of clinical complexity? Well, as we're about to see, the answer is both. A twin pregnancy is this unique path, one that really requires some careful navigation and some very meticulous planning. Okay, let's kick things off with a number, 70%. Now, what do you think this represents? This is the percentage of all twin pregnancies that are one specific type. But which one? And there's our answer. A full 70% of twin pregnancies are dizygotic. That's what we call fraternal twins. And the other 30% are monozygotic or identical. This distinction right here is the absolute first step, the starting block for understanding how any twin pregnancy is going to be managed. So, to even begin managing a twin pregnancy, you've got to start with a fundamental biology. What is really going on in there? What's the actual difference between fraternal and identical twins? Well, their origin stories are actually surprisingly simple. Dizygotic, or fraternal twins, come from two totally separate eggs. They're basically just siblings who happen to share a womb at the same time. Monozygotic or identical twins are different. They come from a single fertilized egg that, for whatever reason, decides to split in two. And in those very, very rare cases where that split isn't quite complete, that's what can result in conjoined twins. Okay, so once we know what kind of twins we're looking at, the next big job is information gathering. Getting early and accurate screening is absolutely crucial because it basically lays out the roadmap for the entire rest of the pregnancy. One of the first tools in the toolbox is something called cell-free DNA, or cfDNA. This is basically tiny bits of genetic material from the babies and the placenta that are just floating around in the mother's blood. It's a really powerful, non-invasive way to screen for things like fetal sex and certain chromosomal conditions. But it has its limits. It can't pick up on neural tube defects like spina bifida, and its accuracy can sometimes be a bit lower in dichorionic twins, and that just means twins who have their own separate placentas. So those initial screens are great, but what happens when they flag something? When a screen raises a question or shows an increased risk? Well, then you need a more definitive answer. You have to move from just screening to actual diagnosis. And that is exactly where amniocentesis comes in. If there are any concerns, let's say an ultrasound shows some increased fluid at the back of a baby's neck, which is known as nuchal translucency, then amnio is the gold standard. It's the diagnostic tool that gives you that yes or no certainty when it comes to chromosomal conditions. All right, now we come to one of the most important, if not the most important principle in managing twins. The risk isn't determined by the number of babies, but by the number of placentas. This single factor dictates pretty much the entire course of monitoring for the rest of the pregnancy. It really all boils down to this. Monochorionic twins share one single placenta, while dichorionic twins each have their own. Sharing a placenta means they're also sharing a blood supply, and that dramatically increases the risk of complications. The rule is just this simple. One placenta, more risk. Two placentas, less risk. And the kinds of complications we're talking about here are pretty significant. They can range from one twin not growing quite as well as the other, to dangerous imbalances in the amniotic fluid. And then there are acute emergencies like a cord prolapse, which we're definitely going to talk more about later, and even some immunological issues. Every single one of these possibilities requires its own very specific management plan. Okay, a quick but really important sidebar here on a question that comes up a lot. Preeclampsia is a risk for sure, but a twin pregnancy all by itself isn't considered an automatic reason to start taking low-dose aspirin. That decision is only going to be made if other specific risk factors are also in the picture. So all this screening, all this monitoring, it's all leading up to this moment, the final act. How do doctors decide on the safest way for the twins to actually arrive? For the most common type of twin pregnancy and labor, the decision really boils down to this one thing. The single most important factor that dictates the entire plan is the position or presentation of the first twin. Is that baby head down or not? That's the key. A C-section is definitely the plan if that first twin is breech, meaning feet first, or in some very high-risk pregnancies where the twins share a single sac. But what's just as important is what doesn't automatically mean a C-section.
Things like the second twin being a bit larger or even lying sideways. Well, in many cases, those situations can actually be managed during a vaginal delivery.
So let's picture this. The first twin has been delivered vaginally. Amazing, but the job is only half done. Now begins this highly orchestrated and often really time-sensitive procedure to welcome that second twin. The process is methodical, it's hands-on, and it's fast. The team will break the second bag of waters and then immediately check for cord prolapse. They'll often start medication to get strong contractions going again. If that second baby is breech, they can even perform an extraction. And if it's lying sideways, they might even try to turn the baby from the outside. This is active management at its absolute most intense. But sometimes an emergency happens. And the one that everyone fears at this stage is a cord prolapse. This is where the umbilical cord, the baby's lifeline, slips out ahead of the baby, cutting off its oxygen supply. This requires an immediate, and I mean immediate, response. The response protocol has to be instant and decisive. There is no time to waste. Step 1. A clinician will manually lift the baby off the cord and replace the cord back inside to get the blood flowing again. Step 2. If the conditions are right, they'll perform an immediate breech extraction to deliver that baby right then and there. In this situation, every single second counts. So, as you can see, managing a twin pregnancy is so much more than just doing everything twice. It's this bespoke journey, totally tailored to the type of twins, the placenta, and the real-time events that unfold in the delivery room. It's really a perfect example of personalized medicine in action, right? And it leaves us with this final thought. How can the lessons we learn from something this complex be applied to make all of healthcare more precise, more predictive, and ultimately more personal?